We're honored to welcome Dr. Robert Kistner and Dr. Elna Masuda to talk about the 30-year anniversary of their seminal landmark paper on venous valvular reconstructions. Dr. Kistner is a pioneer in the field of vascular surgery. He's a former president of the Society for Clinical Vascular Surgery, Western Vascular Society, and the American Venous Forum. Dr. Masuda also is a key opinion leader and the former president for the American Venous Forum and the Hawaiian Surgical Association. Both have been recognized worldwide as leaders and recipients of the American Venous Forum Founders Award. 30 years ago, they co-authored an important paper in the Journal of Vascular Surgery. This seminal paper details their experience over 25 years of valve reconstruction with excellent results and follow-up with up to 21 years. This paper is really exquisite with their description of the protocol and the follow-up. It's a must-read paper. So, Dr. Kistner, I'm interested in venous valve reconstruction as a possible solution for treatment of patients with severe venous insufficiency.
I'm sorry, was that a question?
Yes. So how do you become interested?
How did I become interested? I became interested in chronic venous disease because the patient was unable to go to work. He was totally unable to work because the manifestation that he was experiencing was pain when he stood up. And so whenever he got erect, he would get severe pain. He couldn't tolerate it, no work. He was a 57-year-old Hawaiian male who this was his livelihood, and he needed something done. So he was referred to us to see what we could find out. I can go into how we would do it if you would like.
Please.
All right. So what we did was our usual workup for a patient with chronic venous disease, and that was ascending venogram and duplex scan, an ultrasound scan of the leg. Now, ultrasound was pretty new in those days because this all happened in March of 1968. It was about 56 years ago, I believe. I mean, quite a while ago. And as we did that, we needed to find out certain things in order to be able to attack what the problem was. So his problem was not being able to stand up without severe pain. When we did the ascending venogram and the ultrasound study, we could determine that there's a map of competent, patent, not competent, but patent veins in the left lower extremity, which happens to be the involves extremity. So we had a map of that, but then the question was, well, are there any valves? And are the valves competent or incompetent? So with the ultrasound and the ascending venogram, we didn't get that kind of information, and we thought we invented a new idea, which would be descending venography. In that case, the patient would be on a fluoroscopy table that could be elevated to 60 degrees erect. Not totally erect, but 60 degrees is pretty good. And then we would insert the contrast agent above the area of reflex, not in the foot, not in the leg, but in the groin. Put the contrast agent above the level of where he was having the reflex. And the importance of that was his symptom. We've just turned his symptom around and put it in front of a fluoroscopy. When we did that, we had to have certain information. That is, where is the valve? Where is the vein? And we're looking to find out where is the valve, and is the valve competent. So we did that, and we put the contrast in the agent and elevated him from supine to 60 degrees erect. And to our amazement, he had a huge amount of reflux from the groin all the way down to the ankle. If just by quiet breathing, he had deep reflux to that degree. But when he did something like strain down, it became quite a massive reflux, and it was extremely interesting and told us things that we needed to know. So now we knew with descending venogram that there are valves present and that the valves leak. So we had the information that we really needed to think about maybe we can do something about the upper part or some part of the vein when we knew more what was going on in the lumen of the vein. And that led to a two-stage operative procedure, which we ultimately designed, which the patient on the ascending venogram had shown post-thrombotic disease, but it affected only the calf and through the popliteal vein. When we did this, we had information about the upper area. So we put this all together. With this information, we were able to justify looking into the vein itself. At that point, we felt that we could carry it into an examination of the venous valve, even by venotomy, and explore what was going on. People who had worked in this area previously had gotten pretty much up to this point, but all they did was ligate. For instance, Gunnar Bauer in Sweden ligated the popliteal vein and was criticized for that. But we weren't interested in ligation. We were interested in seeing if we could find a way to fix the problem. So I kind of leave it at that point and then open it for whatever questions you might want to generate from that.
So to jump from the venography to ascending and descending venography to the procedure itself is quite a step. Designing the procedure, explaining to the patient, the first patient that you reported in 1968, how did you make that leap? How did you create that, the valve reconstruction, the reefing up of the incompetent valve cusp? That was amazing.
The patient was totally for anything that might help him. So see, he was really stuck. He couldn't get up and couldn't get around and had severe pain. So we discussed with him that we were in uncharted territory and had his understanding, to whatever understanding he could achieve, to go ahead and take a look at what's happened. So the plan was, we're going to attack both the post-thrombotic disease, which is affecting the lower leg, and whatever we find in the upper leg that might be important as a source of axial reflex all the way down the leg from the groin all the way down. As we did the two-stage thing, the first day we operated on the leg. We fixed the post-thrombotic disease. We felt that was absolutely necessary if you're going to treat this sort of thing. So we did the conventional treatment of the perforator veins and the subcutaneous vein. 4 days later, we put the patient under heparinization, and we had the intent to explore the valve, and go as far as we might. If we could possibly fix it, well, that would be good. If we couldn't fix it, well, other people in the past had ligated things, so we could try ligation, or we could just close him up. As we did this, on the second day, we explored the whole femoral vein, that is the distal common femoral vein and the upper femoral vein. Isolated all of the branches so we had full control, and we could milk the vein backwards and forwards, and we could demonstrate that the valves were the single valve we were after was incompetent. Now, we knew that single valve was there from the descending venogram, so we had all of that information. With that information, then we concentrated on that valve, and when we found it was refluxing, we said, well, there is some movement of something inside the vein. We thought it was worthwhile and appropriate to open the vein through a venotomy, which we did through a commissure of this particular vein. We tried to do it in a way that we didn't injure the cusps within the vein, and that was key in our mind. And so luckily we got through that. And luckily, I mean, there was a lot of serendipity in this, right? I mean, we were pretty lucky people, I must say. As this progressed, we laid the vein open, and when we looked at it, the tissues were totally non-inflamed. They were glistening, beautiful membranes of normal tissue. And we thought, well, you know, initially we thought, well, there's nothing wrong here. Then as we looked at it, we could see one valve was not exactly the mirror of the other valve. So then when we had avalvular bicuspids, that wasn't going to work because those leading margins of the valve cusp have to come to a perfect union in order to make it competent. And that was reasonable, and it seemed possible. When we looked at the valve, it was in multiple furrows kind of lying in the back of the vein on one cuspid, and on the other cuspid, it was just a beautiful valve cusp. So then we thought, well, I don't know if we can fix it, but let's try to take a little tacks in the vein, just like you would with a sail. So we took little sutures through the upper commissure and put it through the edge of the valve cusp on the bad margin, and gradually pulled that cusp up until it matched pretty much the first vein. When we thought we had a pretty good match, and I don't know whether we put some sutures in both valves or not, I don't recall all that, but they came pretty similar, and then we closed it. And when we closed the vein, we all tried to do it so it would have perfect apposition of the valve margin, at least where we started. To our delight, when we tried to milk the vein after we closed the venotomy, it was competent. So then we thought, well, now what do we do? We got a competent vein that has not been done before that we knew about. Our choices were to ligate the vein, or to just close it up, or to see if we could fix it. So we said, well, let's try the little thing that we were talking about. We can take the cusp out. So we did that with several sutures. And after that had been done, we had a competent vein. So we said, we'll keep him on heparin and we'll see how he does. That was great. So the next day, we were making rounds, and we walked up to his bed, and we said, well, you know, good morning, whatever it was. And he said, God, really, I don't know, I can't, but he was saying, I'm well. I feel good. All of the heaviness and pain in my leg doesn't seem to be there anymore, and thank you very much. I really appreciate it. And so this was a total 180 degree for this guy, a very nice Hawaiian gentleman. And so from that day on, there was never a recurrence of the pain for the 13 years of his rest of his life, just by that one repair. And so that left us with having at that time, what do you do with a patient who has a fixed valve, and how are we going to handle it? And so we could discuss that later if we want to. Does that help understand?
That is amazing. I mean, the description that you have of the patient presentation, the new technology that you developed, and the new procedure is, I think, invaluable for practitioners of the modern era. Those concepts still reflect upon what we need today. So thank you. All the way from 1968. This is an amazing story.
Yeah.
Elna
I'd like to say one more thing, and again, just delighted to be amongst both of you, and the information that's being relayed. It's Bob Kistner, because you really showed the world that we don't have to fear touching the vein. In the 1960s and 70s, there was a lot of fear. We were told, even in my general surgery days, don't touch the veins, it's not going to clot. So you showed us with heparin that you can open a vein, repair it, really don't have to fear what others thought, right? So that was a big advancement, I think, of the venous field.
Yeah, thank you. But you know, that's just another step. Before heparin had come in, we learned to use it. Elna, you know, And so that allowed us to do something that really people couldn't have done 10 years earlier
Right.
because didn't have the heparin.
Right.
So
But I think when you talk about descending venogram, I think you bring up a great point, because that's the imaging that is very helpful to determine what kind of vein valve do you have. Is it, number one, repairable, i.e. primary valvular insufficiency, or is it not repairable, destroyed by post-thrombotic disease, which would change the whole surgery? If it's disease, if it's post-thrombotic and the valve is not repairable, it's disease, it's thickened walls, you can't repair it like you described. If it's primary valvular insufficiency, PVI, then you might find that cusp that you can cinch up as you described. And I think that descending venogram, and in some cases, really good sonographers, they can see these valves, but that's the pathology that you can determine pre-op, for those interested in doing the surgery pre-op, to determine whether you can repair it or not.
Well, we were blessed with a tremendous sonographer.
Yeah.
So Darcy Kistner would sit with the patient and day in and day out and watch the valve work and not work, and she led us all the way to where we were going. So big credentials to her. Is just a fantastic teamwork. But I forgot what I was going to say.
Okay, so shifting gears a little bit, this study had long-term outcomes up to 21 years. So the patients were being treated for since much earlier. You started performing this procedure in 1968, and then you accumulated all the data and reported in this series, which I think has some of the longest follow-up that we've ever seen, quite frankly. But even since the last 30 years of this publication, we're still struggling to get good long-term outcomes with venous valve repair. And many surgeons have tried and not done very well. Why do you think that's the case?
Want me to answer that?
Yes, yeah.
Well, it's complex, and people aren't used to complexities in the venous system. They may not be that turned on about it. It takes a lot of workup. It takes a lot of thought. It takes bringing in the radiologists to help out with whatever we need for venography, and a team approach. So those are some of the reasons that a lot of people just wouldn't go there. Now, those who would go there were quite a few who did, and in fact, they did a tremendous job. Some of them found a different way to fix the valve, like Soterai had a way that Paran later used in large series. Soterai had a large series. Raju had a huge series, which he did in another different way. So there were several different inventions of how to make the valve competent. The main thing was they were working on the vein that had valvular reflux, primary valvular reflux. It was not an inflammatory problem. It was not anything like post-thrombotic disease, which destroys the inside of the vein. This was glistening pure membranes, and once you fixed it, it seems to have stayed fixed. I don't know what the limitation is. Maybe there's no limitation to how well it will last. It was 13 years, so what's going to happen to it now? We don't see anything degrading that I know of. But I think the studies are needed to find out what happens at 20 and 30 years, because venous disease lasts a long time.
Absolutely. I agree with you. I think we need those long-term data. And unfortunately, we don't have much of that, especially when we start looking at where the field is going. There's lots of work on developing the implantable bias prosthetic valve that looks very promising, but no device is FDA approved. Where do you think the field is going to be going? Dr. Masuda, do you want to take this one first?
Yeah, I think there are the new devices that are coming up are very promising, exciting. There's a device that's right now, I think, in its undergoing a pilot study, at least has been, and maybe will be the results published soon. But the answer to that is autologous is always better, right? And the problem is we don't have autologous material always on hand. So the answer to the question is, I think there's a lot of future in these new bioprosthetic valves that are being created, and we're looking forward to its durability and its long-term results, or intermediate results, really.
I would throw in one thing beyond that, or in concert with what Elna says, I agree. But, you know, we've gone through plastics, we've gone through metals, and they don't work inside the vein for the long term. Autologous tissue does seem to work. Now the question, I think, is xenogram, is that going to help us out? So it's kind of the going through whatever possibilities there are to make an implantable valve. And it's kind of exciting to see if something can come out of it, but I don't, to my knowledge, that nothing has come out yet.
I think that one of the drawbacks is one of the limitations is that at least the current venous valve, you need to have long-term anticoagulation. It's an implant. It's an open procedure currently. There could be an endovascular option coming up soon. But the anticoagulation is something you'd probably have to continue for a while, and all its other risks.
Agreed, but I think the fact that you went through this process so long ago, and I think a lot of the development of your ideas still are relevant today, quite frankly. The development of this new idea with operating on the venous valves was brand new, and going into the vein and fixing these problems was brand new. And really, I think this paper helped usher in a whole new field of interventions for open venous reconstructions. So thank you so much for talking about this important paper. We're so happy to have you talk about it on the 30th anniversary of this paper.
I have one, so excuse me, and yeah, one more thing. I agree with you 100%. The one question I'm pretty sure listeners might have, the current generation be, so what's the indication today, right? What do you do? When do you apply that? And you know, Dr. Kiss and I had long conversations about this. We have simpler methods of approaching the severe chronic venous insufficiency patients with active ulcers, pain, etc. Now we treat the superficial system, the perforated system, and now the iliac vein system, right? We try to look at these less invasive procedures. So there is a role. I think if these lesser procedures are not even applicable or they fail, don't forget the deep venous valve. Don't forget the deep venous reflux, and look for the valve to repair. Would you agree, Bob?
Yeah.
We all see those patients, unfortunately, where we do everything, including the kitchen sink, and the ulcer is still persistent. So I do think that there's clearly a role for investigating further, looking at deep venous valve reconstruction, or at least examining the deep venous system with a good old-fashioned venography. If you can't get adequate duplex imaging, I think venography is a very good option.
Do you hear anybody using descending venogram in their workup?
Not anymore.
Not anymore.
Not anymore. But we actually have been talking about it in our lab for quite a while. We're very interested in it, especially for those patients where we've tried everything else. There are some other newer technologies, non-invasive and invasive technologies, I think, that are on the horizon for diagnosis and treatment for these difficult to treat patients. They look very interesting. We're trying. We'll find out, hopefully, in a couple of years.
Fantastic. Good. Well, we appreciate the opportunity to discuss all of this and your work. Thank you very much for all of it.
Thank you so much, both of you.
Okay.
You're welcome.